So I guess we'll go ahead and get started momentarily. The way this is going to work, it's going to be really informal. I'm going to pull up the slides. Brady has some stuff prepared too, so that we can go back and forth. But I'm going to pull up the slides, and we're going to go through all of the week 8 stuff, the DLAs, the lectures. And some topics we're just going to quickly go over and say, hey, really focus on this. And then some we're going to try to break down for you guys because, things that he thought was difficult, things that I thought were difficult, to kind of help you guys through that. To make sure that when you're studying, you can focus on good, high-yield information, because some stuff is more conceptual than it is testable. And you need to know it, but you really just need to know it for the purposes of other information. So we're going to go through all that stuff.
So if y'all haven't been in my group before, I recognize a lot of y'all, but if not, I run Scrubs DES. So you can join that on Facebook. I post all the reviews, but also I put in the chat, that's my Google Drive. I post not only the reviews, but a bunch of additional stuff that I found helpful, including like question sets that we've done. For this one, the PowerPoint I did, we're not going to do on Socrative, but there's not as many questions. But if you join the Google Drive, I'll put up a bunch of stuff on there. And if you've been in my groups, I always talk about I really memorizing things if I don't have to. So I really try my best to understand it. If I understand it, I feel like it lasts longer. I don't have to strictly memorize it. So for example, like my first post-read pass, I strictly worry about understanding it. Like my goal after the first post-read is to be able to put up the PowerPoint and explain it to someone. All right, and then after I understand it, then my second pass, then I'm trying to iron out the fine details and start memorizing stuff. I find that less stressful because the first pass, you're not stopping to memorize things. And the second pass, you're really not, you feel better about yourself because you understand the material prior to really memorizing. So the way I set up my PowerPoints is very much based on an understanding concept. And then after that, you can dive into the details. So I have a PowerPoint that covers the entire upper limb. So we're going to hit a lot of the points that I found. And so, yeah, we're going to hit a lot of the high points for the whole upper limb, including the brachial plexus. So, and again, it'll be all posted after. So my goal in making the PowerPoint was that you don't have to take notes. You can just follow along. So, yeah, that's all. Anyone know how to unmute the speakers? It muted. I have no idea.
She muted me, and I was able to just unmute myself. So.
Oh.
I mean, I can hear you. So.
Okay. Rebecca, it might be on your end. Like it must be. I don't know that we can do anything about it. You should be able to unmute us from the program. If you go to this video settings, maybe that helps. Audio and video settings. Okay.
Okay, so if there's no objection, we'll go ahead and get started. I'm just going to go through the lectures that are provided to us from you, and we'll go through it. If I feel like I have some notations on my personal lectures that I want to go through, I'll put that up. But we're going to run through this stuff. So I'm going to go ahead and share my screen. Start sharing. So can you guys see this?
Yeah.
Okay. So this is that before 9 lecture. This is just talking about OI and DMD. So there will be a couple questions on this. This is kind of a tedious.
Hold on. Yes. Okay, I can see it on my. Okay, we're good. Never mind.
Okay.
I think maybe you give it a second, guys, and it'll pop up on your screen.
Yeah. So we'll wait.
I had to physically click on Lindsey's circle thing.
Okay.
I don't know if other people need to do that.
Yeah, so click on my thing.
Click on her face.
Yeah, this is different because on Zoom it like takes up everything and you can't see anything else. So I guess it's just whoever's talking. So okay, cool. So if you haven't done so, put in the chat. Otherwise, I'm going to move on. Okay, so the big thing with these diseases, first, you are going to need to know if they give you a gene, you need to know the gene. And if they specify what type of genetic defect it is, for example, if it's a substitution or anything, you need to know that. So just chart it out for yourself. And then what gene product is affected. So if it's a protein or an enzyme, you need to know that. Other than that, know the presentation. So if they ask you, I mean, you guys have been tested on the genetic stuff before. If they give you the presentation, I mean, they can give you the presentation, expect you to know the disease, them the gene, and they're not going to tell you what disease it is. They're just going to expect you to know it from the presentation. For these, Brady, I don't think the serum level stuff.
I mean, maybe if you just know that CKMM pertains to muscles and the dystrophin protein is a muscular protein. I think more importantly, to elaborate on what Lindsey said, the DMD, the Duchenne muscular dystrophy, is a more serious form of Becker's muscular dystrophy. And the reason is because in Duchenne's, it's a frame shift mutation. So you basically don't get any of the dystrophin protein. Versus Becker's, it's an in-frame deletion. So you get reduced amounts of it. So that's why children with Duchenne's, it's a much more severe case. But just knowing the genetic criteria in that it's a frame shift versus Duchenne's versus Becker's is an in-frame deletion is going to be helpful for the test.
Yes. And any pathology, I don't think there was any histology stuff on DMD and OI, but if you do get a disease that has a characteristic pathology finding, that's very testable as well.
And a buzz, that was the only thing, was that muscle biopsy right there. But another thing, a buzzword for it is for Duchenne's is pseudo hypertrophy of the calf. So it looks like these children's calves are really bulky, but actually it's fat deposits in the calf. And another one is called the Gower maneuver. Yes. Y'all probably have heard of this. That's how the children have to stand up, because a lot of the extensors in their legs, including the calves, don't work properly. So they have to use their hands to stand up. That's referred to as the Gower maneuver.
Yeah. So, and they'll probably describe the Gower maneuver. They probably won't say Gower maneuver. They'll say on physical exam, this patient has to roll over and they like kind of crawl. It's a crawling motion, like on their hands and feet. They'll describe the Gower maneuver, and that should be a buzz for you to go, oh, this is muscular dystrophy. So we just talked about that. This is the Gower maneuver. That's the graphical description of it. And then in this one, it also talks about OI, osteogenesis.
Oh, there it is right there. That's the Gower maneuver.
Oh, yeah.
And just quickly, I covered this in my last review session for the PowerPoint. I posted it to your term page. It's got the skeleton on the front. But if you go to the Scrubs DES page, it's on there too. So I went into detail with the different Becker's versus Duchenne's and the different types of osteogenesis imperfecta and all that. So you can review that. Pixarize has a pretty solid review of DMD and Becker's. Cool. Yeah. Thank you, Diana.
Yeah, I didn't know if I could share that, but it was really helpful.
Yeah.
Awesome.
Cool.
And then OI, this Col 1A1, so important. So important. So it's a nonsense mutation, the copy of this gene. So make sure you are doing that. I think you guys went over that in FTM too, because it introduced OI in FTM too. But again, knowing the presentation of the patient, knowing the gene, Glycine, if they name a specific amino acid that's changed, that is very high yield as well. So the missense single base pair, which results in glycine to valine substitution, anytime they specify something like that, it's really important for you guys to make note of that.
And and again, this is covered in my previous review, so take a look at that. But so the missense mutation, that promotes a dominant negative effect, which is important because that happens in OI type 2, which is more severe. And you could say, well, if this is a missense mutation versus the other one being a nonsense, OI1 being a nonsense mutation, why would this one be worse? And that's because it forms a dominant negative effect. So even though you're making enough of the protein, it's deficient, right? So in this sense, it's better to have a nonsense or less amount of a normal protein than a missense mutation, which is more of an abnormal protein. You get the brittle bones from them both, but this is an example where the missense mutation is more severe. So you can compare that to Becker's and Duchenne's versus OI type 1 and type 2. But these are the kind of differences, or the contrasting genetic modifications that happen that the teachers like to test on. It's easy testable material. You're looking for things when you're reading through that you're like, oh wow, that's a little bit different. Yeah, that's something that you want to take note of.
I would definitely chart it out, whiteboard it out, the differences, because anytime you can compare and contrast something, it's very testable. Okay, so I think we've gone over this enough. So I am going to move on from that one. So this was before lecture 9, so we'll do lecture 9. So this was the flipped case. So if you guys are all right, we'll skip that. So we're not going over those questions. If you guys want to go over, just post in the chat, yes, and we'll run through it really quickly. But since this was a flipped classroom for you guys, he talks through all of those questions. So if there are no objections, I think we went over that material. Okay, cool. So before lecture 10, okay, I want to stress this to you guys. Do not skip over embryo. Don't look, oh my God, Brady. Don't skip over embryo. Don't do it. Some people might try to tell you, oh, don't worry about embryo. It's just a few questions. It can be the difference between an A and a B or a B and a C or failing if you don't look over embryo, because there will be about 4 to 5 questions over embryo on your exams, and it will behoove you to look over this stuff. So what they focus on in embryo is what comes from what, and any pathology associated with a defect in the embryological formation. So we'll go through this.
For sure. When it comes to embryo, like, you could spend a whole lot of time on it, and it is important to look at. But focus, if you want to go high priority to low priority, definitely take the clinical aspects and work backwards from it. Okay, so if they give you like a sacrococcygeal teratoma, which is in your lectures, you want to know, okay, this is formed in the child, but where did it come from? And it's a remnant of the primitive streak. And if you look at that on the embryo slides, you'll see that the primitive streak was early on in the embryonic period. And that's why in the sacrococcygeal teratoma, you'll see 3 germ layers in the teratoma. And so that's important to know, because you can wrap up in your head the idea that the primitive streak was so early of a deficiency that the 3 germ layers were still kind of compiled as one. And that's why you get this formation of it. But like, going beyond that, they probably wouldn't test you on it. But you could easily see a picture of this child with the teratoma, and they could ask you, well, what are we looking at here? And it, opposed to saying it's the primitive streak, it'll say you would find all 3 germ layers. So it's the second order question. But those are the kind of things you want to look for.
Yeah, I agree with Brady. Work backwards with the embryo stuff, because it gets really confusing. You'll notice that all of the embryo slides are very wordy, very compact, and it gets frustrating because it's hard to understand something that is at such a small level. So I have gotten to the point where I go to the end of the lecture, I study all of the pathologies, and then I work my way backwards because then it makes sense to me. And it's like, okay, this is why this is important. Other than that, it's like, okay, why do we care what's going on about this? But so as I'm scrolling through this, like this is a bunch of words. It's just describing everything. Yeah, primitive
you could
group.
you could focus on like bolded words, but even then, you know, it's still a lot of stuff that's just not highly testable. Here's the teratoma we were speaking of. So yeah, they could give you a picture of that and say what's going on, and you could see that there was a problem with the primitive streak, and you get 3 germ layers. So they could even tell you, they could give you a question, say a child came, you did pathology, it had 3 germ layers in the pathology, and they could either ask you where's it come from, the primitive streak, or what it is, and that's the sacrococcygeal teratoma. So those are the kind of things. It's like, how do you test somebody on the primitive streak? Well, you take a clinical application for it, and then you work backwards.
Yeah. None of that looks too big. So the nucleus pulposus, all of that stuff, this is going to be tested just in the postnatal adult, intervertebral disc. Paraxial, intermediate, and lateral, they do like this stuff. I do remember them testing like different parts of the body. What part of the mesoderm are they derived from? So there might be a little chart in here somewhere, but do know what comes from that. Yeah. So yeah. Okay. So.
Yeah, the somites are important there, right there. Go back up. The dermatome, sclerotome, myotome, the bottom left. Yeah, you want to know that. So these somites will divide, and this, from the somites you get either a dermatome, which correlates to the skin, sclerotome, which will end up being the vertebrae, or myotome, which will be muscle cells. So that's an important derivation from the somites.
Lateral plate, this comes into play, I think, in subsequent modules. I don't remember in MSK unless they specify something like incomplete folding of the lateral plate. Okay, so that was the end of that. And then that was the DLA. So we'll go to your lecture. That's lecture 10. Okay, this difference is important. Ectoderm, neural tube, neural crest, because they can say what is derived from the neural tube, what is derived from the neural crest, or they can say posterior pituitary, what is the embryological origin of the posterior pituitary. But these are high yield, very high yield, and it doesn't go away after MSK. And neural crest cells, they love neural crest cells.
Yeah, always. Yeah, know what comes from that. I forget the mnemonic. I'll look it up real quick while you talk.
So this kind of thing, it's so funny how this matches up. We just went over this kind of stuff in greater detail, but knowing this on a conceptual level, just so you understand it, that's going to be important. So you just have ectoderm, it folds in on itself, and then it pinches off. So this all kind of comes from the ectoderm, but now you have the neural crest and the neural tube and then the notochord right here. So this slide right here, when they explain it, it's conceptual. It's for your understanding to answer other kinds of questions. So it's not necessarily, they won't necessarily pull questions from here, but you do need to have this general understanding of the formation of the nervous system to really appreciate some of the pathologies that they're going to explain to you. I don't think this is a repeat. of everything we're doing right now.
Oh yeah.
Yeah, all of the stuff. Oh my goodness, we went over this in heavy detail.
Oh, so I'm sorry. So the neurocrest, the mnemonic is motel passes. If y'all don't use first aid, I would highly recommend it. I know I preach this all the time, but a lot of the things in this mnemonic you haven't really covered. Just think of the neural crest as the peripheral nervous system versus the neural tube is more of the CNS. But yeah, if you can look up and see what comes from the neural crest, you won't miss that question on the test.
It makes total
Oh
sense.
shoot,
Though.
hold on.
Like if you know this, it makes total sense that the neural tube would be the CNS and the neural crest would be the PNS, because the tube, this is going to eventually become the spinal cord, and then at the rostral end at the head, it's going to become the brain. And so the neural crest that's overlying this tube right here, this is everything that kind of complements the CNS. And so again, while they're probably not going to pull questions from this is going to help in your understanding and answering other questions. And so when you go through these, knowing what's conceptual and what is like the really big testable information, and which gets easier over time. I said that CPR, I started to pick up on the patterns, and when I started studying, I started realizing, oh, this is probably how SGU is going to test it.
You could look at these two slides are high. Yeah, it's on page 613. Thank you, Diana, of the first aid 2020. So yeah, this page is a good page to print out the neural tube derivatives. And again, those are all going to be CNS derived cells. And then if you go to the next slide will have the neural crest cells that you need to know right now. Okay, yeah. So like Schwann cells are for the peripheral nervous system, but there's some weird ones like melanocytes. You don't want to get tripped up on that because that may confuse you, whether it's PNS or CNS. But yeah, so know those. And this too, right here. Yeah, that page with the graph, yeah, or the table.
Yeah, this just kind of condenses it for you guys. Do you remember this being in our slides, Brady?
I've never seen that in my life.
I mean, we've seen it in NB, but I don't remember this being in our slides in MSK.
Oh, I don't know.
I don't know. It doesn't matter. Do you remember them talking about myelination?
Yeah, I think. I think they brought it up. So the main thing
is the difference between CNS and PNS.
Yeah, sure. So in the peripheral nervous system, Schwann cells are going to myelinate the cells. In the CNS, oligodendrocytes. And just another point, like Schwann cells will only myelinate one neuron, where oligodendrocytes in the CNS will myelinate multiple. So beyond that, I don't think you need to know.
Yeah, the oligodendrocytes have all of these processes, so they can like attach to multiple different CNS neurons, where a Schwann cell is just one cell and it's going to do one part of an axon. So one axon will have multiple different, they like to link myelination to, yeah,
for sure. So like in the PNS, obviously, when you have an injury to the peripheral nervous system, that's gonna repair itself much more readily than in the central nervous system, which is why paralysis is is considered permanent, unless it's sort of like a spinal shock situation.
Yeah. Okay, so now they're getting into some pathology. So this is where you really got to start paying attention, and you can relate it back to the previous slides. So neural tube defects, they love neural tube defects. Know that it, in the first few weeks of pregnancy, it's the folic acid, the folate that's deficient. That's going to come a little more into play in subsequent modules, but they love that. Spina bifida, so this is a neural tube defect. That's what spina bifida is. And so there are types. Know the different types. The occulta, it's no neurological defects. The tuft of hair. Tuft of hair is a buzzword for spina bifida occulta. And then with the cystica, there are two types. There's a meningocele and a myelomeningocele. And the difference between the two is the tissue that's in the and the bulge. So the meningocele is meninges and CSF in the subarachnoid space. But if you get the myelomeningocele, you're also going to have meninges, cords, and nerves. So make sure that you know this. And then the myelochesis is open.
So like for the myelomeningocele, like the longer the word, the worse it is, right? Because you're adding stuff to it. So like a meningocele, it's just going to be meninges, but if you add the myelo to it, that's the neural tissue. And for the occulta, like this little girl in the next picture, those patients are usually asymptomatic. They usually diagnosed by that tuft of hair in the back. If you should, the little girl I think has it in the next picture.
Yeah, and so if they give you
you see the
an
tuft
image
of hair.
like this, if they give you an X-ray, MRI, CT, make note of that, because they can put this on here, give you very little information about the patient, and then you have to diagnose the patient. So don't be surprised if you get an image like this on, like if they talk about a pathology and they give you a very basic presentation, the image, and they could say, you know, what is the deformity or how the deformity was made. So this is incomplete fusion of the, whatever that's called. It's up here. It was one of my questions. The arches, yeah. So that's super, super important. Yeah. So this is just specifically going through those marrowencephaly.
Also, like anencephaly and merocephaly are very similar, but it's incomplete closure of the neural tube, but it's at the rostral or head end. So rostral refers to head and caudal refers to tail. So yeah, the spina bifida are caudal or tail end incomplete fusions.
You talk a lot about this in term 2.
Yeah, for sure.
Oh my God, I'm having such flashbacks now. Okay, so that's embryo. Please do not skip over embryo. Somebody told me that an upper term said, don't worry about embryo. I absolutely 100% disagree with that statement. Don't spend hours and hours on it, but if you don't look over embryo, it could be the difference in a letter grade, because there will be a handful of questions on embryo on every single exam. So please do yourself a favor and go over that stuff. Okay, imaging and clinical anatomy. This is a little bit straightforward, so let's go through this and see. So this is just orientation right here. These first few slides, they're really just trying to get you to know how to read. Oh, these kinds of injuries. You need to know these injuries, and you need to know which ligament is associated with these injuries. So there are a bunch of questions in your Gray's book about these. So make sure you know the difference. One of them is anterior. One of them is going to be the posterior longitudinal ligament. So know the hyperextension, hyperflexion injuries. That is, they point it out and they have an entire slide dedicated. So you know it can be testable. This is, again, just a orienting you. In another one of your lectures, they also talk about kyphosis and lordosis. You need to know the difference between all of these spine curvatures. Know what is normal, know what is abnormal, and know how to identify it on an X-ray.
So what helps me, obviously scoliosis makes like an S, so it's a lateral deviation. But kyphosis, think of an elderly person kind of hunched over, and so it's a increased curvature of the thoracic spine, right? They're hunched over. Whereas lordosis, think of a pregnant woman, like they kind of arch their back, you know, to hold the baby in front to kind of even out their weight. So it's an increased curvature of the lumbar spine. That helps me keep it straight.
Yeah, and I just lordosis lumbar. That's how I
always that works too.
It. Yeah. Oh, this wedge fracture. I remember getting a couple of questions in the Grays wrong. It took me a while to understand this, because I believe scoliosis, like congenital scoliosis, you can get this wedging.
That's why there's a curvature, because you don't have the same size vertebrae, so or disc spaces. So that's why you get like a wedge shape laterally, and it'll kind of shove the spine to the lateral side. Yeah, I do actually. I remember something like that too.
Okay, there are a couple under this: Klippel, File syndrome, cervical vertebral fusion.
Oh yeah, and so for scoliosis, the diagnostic test, if you see that guy bending over like that, where you're just looking at his back, that's how they diagnose it. They have you kind of bend over in that fashion in front of you, and then they see if one of your scapula kind of is elevated above the other one. So they could give you that in the question stem. They usually check that like in grade school.
Yeah, did anybody else? I remember them coming through and we all had to do that bend over thing. And as a kid, you don't know what they're doing, but they're checking for the scoliosis, because that's how you can diagnose those things as a kid. Make sure. Yeah. Okay. This is talking about just different views, I think, and they're orienting you to the different processes. Okay. You need to know, if you're looking at an x-ray, the difference between like the lumbar and the sacral area. And it's actually pretty easy, but then they say like the lumbarization of the sacral vertebrae versus the sacralization of the lumbar vertebrae. What it means is that at that junction, those vertebrae are getting very kind of similar. So even though it's a lumbar vertebrae, you are going to have some similarities to the sacral region, and then vice versa. So just knowing those terms, knowing that concept, that
hopefully we'll come across an image and we can make sure we show them where L5 versus S1 is.
Yeah, it'll probably
it's hard to tell there on that one.
Yeah, those two aren't. So okay, yeah, so left shoulder droop and difficulty elevating the shoulder. Okay, so which nerve? Okay, do y'all want to do this question? Do you remember this question? You can put it in the chat if you want, if you remember this, if you understand it. C, spinal accessory nerve. Okay.
Yep,
we kind of agree on C. Yeah. So again, when you're approaching these questions, and I've been talking about this all week, I had a really hard time figuring out how to answer these long MSK vignettes because my brain would be going in multiple different places at multiple times. Take it step by step. Step one is identify the muscle, because they're going to give you an action or an action that's been affected. So they can't do this. Identify the muscle. That is your step one every single time. Then you can relate that back to, okay, this muscle is affected. What is its innervation? And then you work backwards from there. But whenever you see these kind of the questions, and especially if you get these long vignettes that are giving you multiple different presentations of like one nerve or like a set of nerves, make sure that you can identify the muscle first and then work your way backwards from that.
So when we get to the upper limb, I'm covering a good bit of this, like how to approach these sort of questions. But one other thing they like is wing scapula, which is the serratus anterior. I think the best way to go about answering these questions is by doing the Gray's questions. Unfortunately, the lectures only go so far as for your understanding. So specifically for MSK, I learned significantly more from doing questions than I did from the lectures. 100%. So you're gonna, yeah. Don't feel bad if you're getting some of the questions wrong. Consider it a learning experience, because a lot of the material you need to know is not exactly straightforward in the lectures. So again, my PowerPoint
are very one-dimensional. The lectures
are
extremely one-dimensional.
My PowerPoint does go into a lot of the things that weren't really clear in lecture, because I made a list last term of everything that I was like, this is not clear, I need to know this. So I basically put that into a PowerPoint for you guys that we'll go through in a little bit.
I have a question about that for you guys, actually.
Yeah, what's up?
Like, I don't even know what muscle. I'm just pulling from the PowerPoint. It was something about, 90 degrees or not. And then in grays, they actually don't mention that at all. They more mention like protraction and retraction of the shoulder. So should we kind of combine both the PowerPoint and the grays answer, or focus more on the grays answer? There's just a few where they didn't overlap as I was expecting.
Yeah, so usually there's a primary movement for the muscle, but it's all fair game. Like the serratus anterior, the primary movement you're going to think is from 90 degrees to above your head. So they could tell you that. They can say she had problems combing her hair. Anything that goes from 90 to above the head is fair game, but it also helps in protract or retracting. Is it protracting or retracting? It helps hold
something. Yeah, it caught me. That one specifically caught me because I was like, oh, I memorized, you know, the 90 above head, you know, abducting and whatnot, and then all it asked was the protraction. So it kind of just
okay.
Yeah. So
didn't know if it was
protracts. Like okay. Yeah. So it helps to protract the scab. So again, that's more low yield than the actual above the head movement. But yeah, technically it's fair game. But again, you'll see a lot of repetition in the grace questions. The more the questions repeated, the more high yield you can consider it.
Okay.
Yeah, but definitely knowing like the supraspinatus does 0 to 15, the deltoid does 15 to 90, and then the serratus anterior and trapezius does 90 to above the head. They like those values.
Okay, that's probably why they get that more in the PowerPoints.
Yeah. So a little note on that, the difference between the trap and the serratus anterior going above the head. If you do that action, you feel the trap really engage when you try to lift your arm above the head. And the serratus anterior, the main is going to be that scapula, keeping it right there. And so make sure you know the difference between the two. I think in your notes, it does define like initiation of abduction to 15 degrees, then to 90 degrees, the deltoid, and then above your head, it's really that trap muscle. So make sure you know what each are doing really well and map that out and group that out because that's going to be really important. But on the grays thing, I've had a lot of people say, well, I don't really want to go through grays until I know this information really well. No. I would argue that it is going to help you because the slides are very one-dimensional, extremely one-dimensional. And I didn't understand this information very well until I did my grace questions and I started reading the explanations, and because it puts it into context for you. And so that's when you can really start training your brain. And then I've had other people say, well, I'm worried that if I go through these questions right now, I'm just going to memorize the answers and it's not going to help me. I would also argue against that because number one, you have enough grace questions that you're not going to memorize all the questions, like maybe the easy ones, but that just means the repetition is working. But those harder ones, the more you go through it, when you start realizing that if you feel like you've memorized the answers, it's really just because now you know these buzzwords, you know the presentations, and I would argue that it's actually helping you remember this stuff because some of this stuff gets really, really tricky in the presentations, and those explanations going through those questions is going to be the best thing that helps you. So
if I put it in the chat, if y'all don't use the Inkling app, y'all should get it for your iPad or your phone or whatever. You just put your code in for the book and you can answer the questions interactively and it tells you the answer right away. So opposed to having to answer it in your book and go flip to the page.
I didn't know the Inkling app.
Yeah, it's so much faster. It's so much faster.
I literally just downloaded that last night and it is awesome.
Okay, I'm gonna start doing that.
Still haven't received books. Oh my goodness. Do you have a digital copy of Grace?
It's in my Google Drive. The digital Grace is in my Google Drive. So go get it, as well as the First Aid 2020 version.
Okay, cool. She's got it. For the Grace questions, which one would you recommend? You want to do back, upper limb, lower limb, and most of the embryo questions. They do. Yeah, I did all of them, all the ones that pertain. But you know, they do send out a list.
Yeah, there's a list in the practice questions.
Yeah.
Yeah, on Sakai.
I would try to do the questions with the lectures. Like, so ideally you would be doing upper limb right now and you would be finishing those up so that when you get to lower limb, you can kind of start doing them.
Because upper limb is kind of hard when you get into the wrist and the hand.
Yeah.
There's so much that can be asked in the wrist and the hand. It gets really hard. The ones they suggest, just the ones they suggest.
So yeah,
Don't.
I would try to contact the school and see if you could get some sort of access to Inkling. I think on the app maybe you could pay for a partial subscription, but you shouldn't have to do that. They should accommodate that.
There's a way you just take a picture from the first page of the Gray's book, and then you just download the Inkling app, and then once you have the book through that app that is the Gray's book, it will just automatically download to your Inkling app.
You don't need a code?
No, because you already put I don't know what the book, it's like it starts with an E. That's the website. You go on there, and then you redeem the code on there, and then you download the Inkling app, and it just automatically uploads to the Inkling app.
Interesting. Okay. Well, I would definitely look into making sure you have that digitally, because it's so much faster. You could just go through questions like really fast. Okay, cool.
Okay, so if we want to go back to the lecture, lumbar puncture. Brady and I were just talking about that before you guys.
Wait, hold on. So, yeah. Rebecca, I would probably do the ones they suggest first. The problem with doing all of them is you're going to come across a lot of them that you just haven't done yet. Like they're gonna recommend doing some abdominal questions, but 90% of the abdomen questions pertain to the organs. So you get to a point where you're like, oh, do I need to know this? Do I need to know this? And a lot of them you could rule out. So I would go with the ones they suggested. If you have time after, you can scroll through and just see if there's any. I just hate for you to start stressing out about things you don't need to know yet. So that's why they recommended some.
You're also going to find out what they think is important when you go through those Grace questions, because the concepts are going to repeat themselves, and you're going to know, oh, they really like this concept. I better learn it really, really well.
The first 20 questions are about wing scapula. So if you don't think that's on the test, you're wrong.
Those are like the practice questions, though.
Does everyone have a wing scapula? Why are we talking about this? Okay.
No, that's the only way I remembered that for the test, was those first few questions in gray. It's like, what? Yeah. But okay, so, lumbar puncture.
Cool.
The big thing about this, you need to know the location, and the big important thing, the clinical reason why there are two pops is so you know. If you're in the epidural space or if you're in the subarachnoid space, because the epidural space is where you're going to put an anesthetic, for example, a woman in labor, and then the subarachnoid space is where the CSF lives. You do not want to put anesthesia in the CSF, because the CSF is in contact with the entire central nervous system. So that's the clinical importance of that. So the first pop, the second pop, know what those pops are going through, and then know the spaces. So that first. Someone have a question, or is your mic just unmuted?
I think it got unmuted.
Okay.
Nicole, you have a question? Okay.
Yeah, so ahead, know the first pop, what tissue it is, what space, and then the second pop, and then that space. That's super, super important. It's very clinically relevant.
They also like the question, what is the last ligament you go through before you get into the spinal cord or into the dura, and that's the ligament of flavum. Okay? It makes that V, so you have to puncture that before you get to the dura.
Yeah.
I think Nicole, your mic got unmuted somehow.
Oh my God, I'm sorry.
No worries.
Okay. So, and then LP, it's between L4 and L5. That's usually the one they're going to give you. You can do L3, L4. If they're not going to give you L3, L4, and then L4, L5 as answer choices, it's going to be very evident which one it is. They're not going to try to trick you with that. You just need to know the concept, and you need to know where that is. They're not going to put those two together and expect you to know, okay, which one's better.
And I explained this in my group, But so the idea is that the spinal cord ends at L1, L2, right? So you definitely don't want to try to get a CSF tap there, right? You're going to hurt the patient. So after L1, L2, you have the cauda equina, which literally means horse's tail. So the idea is that if you're going around L3, L4, L4, L5, it's almost like putting a needle through hair, right? The hair is just going to kind of separate, and you're not going to puncture the nervous tissue of the patient. So once it separates, then you can pull out the CSF. So that's the whole idea behind going below the point at the what's it called? The
Conus medullaris.
Conus medullaris, which is the end of the spinal cord, which is typically around L1.
And they make a distinction between pediatric and adult. I don't remember them actually focusing on that very much. It was just like a definition, knowing that the pediatric, it's going to end differently. And so at an adult, it's kind of going to end higher around L1, L2. But I think for both pediatric and adult, you're still going to go L4, L5 for an LP.
Yeah, if they give you, they may do L3, L4 for a child, but it should be pretty straightforward.
Yeah, but they're not going to try to trick you with that, or at least they didn't try to trick us. I don't remember. Just know that concept. Okay, so we did before 11, so now let's do 11. Okay, so this is exact same. They're just orienting you. This is really just to show you how you can look at an x-ray and see if there's a deformity. So if these are lining up, you're good.
Yeah, go back. Let's just point this out. Okay, so if you have hyperextension of your head, right, your head's going to go back. And if you do put your head back, you kind of feel it stretching in the front, right? So this is hyperextension. So if you hyperextend your head, that green line right there, that's what's going to tear. That's the anterior longitudinal ligament. Okay. Now this tripped me up for a while, and then like a light bulb went off. So that red line is the posterior longitudinal ligament. Okay. So if you well, let's just do this first. So the spinal cord actually runs between them. Okay. The cord is in between there. And then those spinous processes kind of jut out. So that blue line correlates to the spinous ligament, supraspinous ligament. And then the interspinous ligament would be in between them. But it's important to recognize that the anterior longitudinal ligament is the green one, and the posterior is the red one, and that the cord actually runs in between it, so it's protected.
So this is an important C1 and C2. They pivot on each other because of the dens. If you damage this area, there is a lot that can go wrong. So the hyperextension stuff, the hyperflexion, all of that ties into it, and it goes into here. So fell asleep on the chair, right-sided neck pain due to forceful forward movement of her neck and shoulder. And so they're giving you a clinical presentation. It's a forward movement, shows she's going there. And so you can, that posterior longitudinal ligament can get stressed if you are doing that. Or the whiplash effect, you'll get the anterior. But so odontoid fracture right here. So you see the C2. You can see this coming off here. And this is, if you get displacement of this bone right here, fracture of the dens, you can get damage to the spinal cord, because if that dens comes off, depending on the grade of the fracture, and they talk about it right here, you can damage the spinal cord pretty heavily because it's in that space and it's kind of in that crappy exam to have online. This was the first exam we did online, guys.
Yeah. Look, throw
this
a game aside. Do whatever you need to do. Yeah.
First exam we had online.
So,
you do not need to tell us that.
For these dens fractures, it's important to know that a type 2 fracture is the worst. And that's because that transverse ligament will lie right on Go back to the previous one you had. There we go.
Oh,
See that type 2?
sorry.
There you go. The transverse ligament lies right where that type 2 fracture is. So if you fracture it there, it can compress on the vasculature there, and it'll give avascular necrosis, or decreased blood flow to the tip of the dens that broke off. So typically they consider a type 2 fracture the worst.
Yeah. Okay, so this is kind of just reiterating that. So, okay, Hangman's fracture. You guys need to know the terms spondylolysis, spondylolisthesis. Those are very important to know, concepts to know. So this fracture, since it's a fracture, lysis, the suffix lysis means to cut, or but that would be a fracture.
It also, so again, this is the longer the word, the worse it is. But if you see like that little green line, you see how there was anterior displacement of the bone. So you actually got spondylolysis and spondylolisthesis too.
Mm-hmm.
So the point, typically, if you're going to have an anterior shift, like spondylolisthesis, you're going to have a fracture too. But
Yeah.
they consider any sort of anterior dislocation. That's the only way it could go, is anteriorly. So that anterior dislocation is going to be spondylolisthesis.
Yeah, so spondylolisthesis is that dislocation, where spondylolysis is the actual fracture. So you get spondylolisthesis following spondylolysis. However you say that.
You got it. Yeah. They should show a picture of the Scotty dog coming up.
Yeah, I think it's down here. C1 burst fracture, really, Jefferson, is C1. They're talking about the transverse ligament. They're talking about the burst fracture. So this burst fracture isn't going to be really bad unless you do damage a transverse ligament, because since you're bursting outwards, you're actually creating more space for the spinal cord. But if you get the dens coming in here because the transverse ligament isn't blocking it, then that's when you can get compression of the spinal cord, or even like a transection of the spinal cord because of the bone in there. So just knowing that it's in that area. This is just showing you an AP view. Yeah, this is just showing you the view. Okay, so I'm pretty sure this is talking about, okay, this is a compression fracture. So you need to know what the compression fracture is going to result in. So you have the, it's the decreased body.
Yeah, right. So if you think of someone like jumping from high up and landing on their feet, so your spine's going to be compressed directly down. So typically you can get a compression fracture. So the vertebrae, which was this big, is now going to be this big. So you lost 2 inches of height or whatnot. But that's the idea. The vertebrae is actually compressed. Similarly, you could get like a wedge type fracture. So it's not the vector is not straight down, so you're not going to get a compression. But like, for example, if you're wearing a seatbelt and you get in an accident, you could get a wedge type fracture where part of the body is broken. So it's similarly to like the scoliosis type effect, where opposed to the vertebrae being squares or rectangles, they're kind of on a wedge shape.
But these are good. Please do not look at your hand in the test.
All I was saying is, if you're gonna do it, like make sure like you put your hands up. Don't like start looking down like you're cheating and stuff. So yeah. As long as it's visible, I think they understand.
Your eyes need to be trained towards the screen. So, I mean, you can do hand movements, but don't like put them in front of your face.
Right.
Don't just be very discreet about it. The AI will flag you if you have a lot of stuff going on in your camera view.
If you forget the sensory innervation of the ulnar nerve, you catch your funny bone, if you like, and then you can, I don't know if y'all have ever done that, but actually, if you hit your funny bone and you feel your ring finger on each side, you can feel that the side that the ulnar nerve innervates actually tingles and the other side doesn't. So yeah, it's a good trick if y'all want to try it in your free time.
Yeah. So that's that. Okay, this looks like a burst fracture. Yeah. So they could give you an image like this, but like know the definition of a burst fracture, know the how they're going to present like status post what. But okay, this view, I think this is where they're going to get into the dog. Yes. Okay. So the pars interarticularis right here, you can see it on here, but you're not going to be able to really appreciate a fracture in a lateral view. So if you have an oblique view, you get Scotty the dog. And so the pars articularis is really evident right here in the neck of Spotty. And so you can have spondylolysis, again, that means fracture. And you can see it in the oblique view. So a pars articularis fracture, you need to know it's in the oblique view because that's when you're really going to be able to see this bony structure.
And keep the buzzwords with spondylolysis, that little neck of the dog right there, that is the pars interarticularis. That is actually what breaks. That's the weak point that will fracture.
And then listhesis, remember that's the dislocation. So right here, we're showing a posterior dislocation of L5 from the spinal cords.
I think they consider that, I think that's still considered
slipping anteriorly, yeah.
So the more superior disc will slip anteriorly. So that would be considered spondylolisthesis. But yes, somebody asked about the question. If they put an x-ray on the exam, it will be obvious like this. Like if you drew a line down L3, down L4 and wanted to connect it like you could to L5, right? On the other side, you wouldn't be able to because of that. You could see the anterior displacement. Oh, look, here's a good example. So if you're trying to say where's L5 and S1 on the image on the left, look how L3, L4, and L5, they pretty much look the same, right? L5 is kind of looking a little different. And then S1, it's completely different, right? It's turn. You can't go with the turn always because some people it's more straight up, but you can see it kind of has a different appearance, right? It's not really square.
Yeah, this is a really obvious turn. So a lot of times you can see, even if it's just a very discrete turn, you can see it, but you do see a difference in the shape of the body of the vertebra from L5 to S1, but they can put a picture like this. I mean, I don't know if they would put an MRI image on there, but they, like an X-ray, they'll probably put an X-ray.
What they can do, I think what they would do is they would give you a situation where they would give you some sort of herniation. Mm-hmm. They would say you had an L5 nerve herniation, and then they could mark.
They won't even give you an L5. They'll point. This is where the herniation is, and you have to know which intervertebral area this is located. So make sure that you can recognize this on. Okay.
If you're still confused about like the spacing and stuff, my last review, we went over it and I illustrated slides about where the nerves exit versus cervical, thoracic, and lumbar. So I try to illustrate that there. Yeah, for sure, it's high yield. So look at my MSK1 review. I'll put there's the access to the drive again, but it's on your Facebook page too, your classes.
Yeah. Oh God, what was I gonna say? Oh, so we're looking at MRI here. Is this T1 or T2 weighted? Do we know the difference? This is from your first week 7.
T2 weighted?
How do you know?
I think the fluid, the CSF fluid is either black or white.
It's white actually, yeah. And so like you can see, so it's tricky because a lot of times if it's T1, it's fat weighted. And if it's T2, it's fluid weighted, but a lot of time fat goes with fluid. So like if you look at the back of the patient, like that's fluid and fat, so it would all light up. So you always divert to the CSF in the column. If the CSF lights up white, it's T2 weighted because the CSF is fluid, it's not fat. So that's the first place I always look. Again, this is
tells
T2.
you right here, T2.
Yeah. See, so you can see the cord is actually what you're looking at. You're looking at the cauda equina. That black or gray area in the middle is the cauda equina, and the white area around it is the fluid or the CSF.
Mm-hmm. Okay, so knowing this, annulus fibrosis, nucleus pulposus, this was asked in my PLG session. So it's the nucleus pulposus that's doing the bulging. So make sure you know this structure and what's actually bulging out.
You know, Lindsey, I can't remember the embryology, but I know you need to know where the annulus fibrosis come from and where the. So wait, which one? Where's the nucleus pulposus come from? And where's the annulus fibrosis come from?
The notochord for the nucleus pulposa.
Okay, notochord for nucleus pulposa, and the annulus fibrosis is.
I think that's the scleromatome, the vertebrae body, and the ribs. I think. I don't know.
I'm not sure. We may have to look that one up. Yeah, but so the nucleus pulposus is from the notochord, a remnant of the notochord.
Right, and then the fibrous annulus fibrosis is a mesenchymal.
Mesenchyme,
Correct.
that's what I was looking for. That's it. Yeah, make sure you know those. Very good. Oh, here we go. Let's look at this real quick. Go back up. Okay, so like
This one or this one?
this one right here. So
Okay.
for the cervical, if you're looking at C2 and C3, C3 will exit. Again, on my review, it's better to look at the illustration. But the problem is, like with the lower nerve exiting first, like C3 exiting between C2 and C3, is that you have an extra cervical nerve. You have a C8. So it bumps the thoracic nerves down, which means between T2 and T3, T2 will exit, right? Everything's bumped down. What's tricky about the lumbar part is, so if you look on the picture on the left, between the vertebrae L4 and L5, L4 will exit, but it exit above the disc, so it's spared. When the disc is herniated, L4 will be spared, so the disc will clip the next nerve going down, which is L5. So if you say L4, L5, what nerve exits between them? Well, L4 does, but it's spared because it exits above the disc. L5 is what's injured. Okay, so you need to wrap your head around that because there'll definitely be a few questions about that.
Mm-hmm. It's very high yield. Okay, so this is exactly what we were just talking about.
And when in doubt, if you're confused about it or whatever, and a test is coming up, for cervical, it's below. The one below exits. For thoracic, it's above, and for lumbar, it's below. It's compressed. If you do which one's injured, below,
Yeah.
above, below.
So the cervical and thoracic, you can kind of get down really quickly, just simply because you have 8 cervical nerves. And so knowing that orientation, and then you transition to the thoracic spine, you just switch from the above to the below thing. Then when you get down to lumbar, that's when you get a little tricky. And so, and it's because those nerves are a little longer down there. And so they're, you're not, like Brady said, the L4 is going to be spared right here, and you're actually going to compress L5. So make sure you understand this concept. Okay, we talked about that in great detail. So I don't think we... Sacral caudal epidural anesthesia. Oh.
I think we're good. Yeah, that's a weird one. I wouldn't worry about that. Is this that long DLA?
I don't know.
I think it is. I covered this stuff in my review last time too with the CYP, the polymorphisms and stuff too, if y'all want to look at that. I know it's long. Focus on the clinical stuff.
I have a question on that.
Yeah.
Are they going to bring back stuff like 6-mercaptopurine and other stuff from FTM2?
So, well, Well, so the TMPT deficiency, the 6-mercaptopurine, is covered again in MSK because it's covered in this DLA. So that's a great example of something that's technically cumulative that kind of builds upon itself, right? So personally, I never look back at the cumulative stuff. I've done well on it because I think they keep it pretty generic. But yeah, so that's a good example. Like you covered it in FDM2, but again, it's covered here. But it's not super high yield because he only does a couple slides on that. But the things in the DLA such as malignant hypothermia, super important, the ranitidine receptor, and the calcium influx, that's important. The CYP2D polymorphisms, when you talk about metoprolol versus codeine, that's important. And then he dives into the triplet repeats, which is super important as well.
Mm-hmm.
You need to know the genetic basis of those and everything.
Don't skimp on those because there will be enough questions in genetics that, again, like embryo, it can be the difference of a letter grade for you.
Hey, Lindsey, I could take over and use my PowerPoint for this, for the arm if you want.
Yeah.
All right, let's do that.
So
all right,
he's going to share his screen. So I think you can just click on his little window and you can expand his screen.
Yeah, let's get it set up.
If we know the DLA slides, is that enough? I don't do the textbook readings.
Never.
I never do the textbook readings.
Can
you graduate?
Talk about the coding or
yes.
You're an ultra metabolizer with not coding but the metropol one.
Yeah, so this is how it works. Okay. So so let's do metoprolol first. Metoprolol, when you take the medication, it's active. Yes, I'll post these slides after for sure. When you take metoprolol, it's active already. So it's the job of the liver or the CYP2D6 to inactivate it. Okay. So if you're a poor metabolizer, you're not going to inactivate the metoprolol fast enough. Therefore, there'll be too much metoprolol in your body. Metoprolol is a beta blocker, so it could cause bradycardia. It could cause low blood pressure. Now, codeine's the exact opposite. When you take codeine, it's inactive. Okay, it has to be activated to morphine. So if you're an ultra rapid metabolizer, you're going to take the inactive codeine and you're going to metabolize it too fast. Therefore, you'll get elevated levels of morphine or the byproduct of codeine in your blood. So they're opposites in each other, and it depends on whether you take it and it's active or you take it and it's inactive. Does that help?
Thank you.
Okay. Okay, can you see my screen, Lindsey?
Mm-hmm.
Yeah, okay, cool. So yeah, you don't need to worry about taking notes. This will all be posted after. So what I wanted to do was kind of go through the things that tripped me up. So again, like I said earlier, the more I can understand, the less I have to memorize. So unfortunately, some stuff you just have to memorize, and I'll put that on here too, some of the tricks. So we'll start with the shoulder and work our way to the hand. Again, this is the DES page. Everything will be posted there and on Lindsey's page as well. Also, if you go to the Google Drive, I'll put a bunch of extra stuff in there that I found helpful, tables, questions, all kind of stuff. Graze is going to be, like we stated earlier, your best friend. You're going to learn more from doing Graze than anything else. All right, we're not going to do Socrative. I have a few questions just to kind of hammer home the topic. But it was brought to my attention, about the X-rays. So I did include really important X-rays that I think may come up on the test. These questions have been chosen for a reason, and the topics that I chose, they're high yield topics. So consider this all high yield. Okay, so when you look at this, what are we talking about here, right? The acromioclavicular ligament. And that's because the clavicle is separated from the acromion, right? You can see that here. You could say the corticoclavicular ligament may be torn. It looks a little separated here, but that wasn't an option. So you could, this is very obvious. Even if they gave you an option, this one's more obvious. The reason the clavicle is pulled anteriorly or superiorly is because the sternocleidomastoid, that muscle in your neck, is pulling it upward. So if we look here on the left, this is a normal image, and then on the right, this is a shoulder separation, right? So this acromioclavicular ligament is separated, and also you see the space between the corticoclavicular ligament. Don't worry about the coracoacromial ligament, because it's going to be pretty much safe in separations, right? Because it's down here, it's not attached to the clavicle. These are the two you're going to need to worry about with shoulder separations. All right. So I know it could be a cool party trick to be able to draw this out for med students. Nobody else cares, I promise. But the important thing is that you know the branches, right? The branches here, where the nerves exits, and the cervical roots. So we'll go into this. The mnemonic for the different sections, it's real Texans drink cold beer, right? Roots, trunks, division, cords, branches. So we'll start with the roots, right? So what I like to do when I study, I try to categorize things together. So Herb Duchenne's palsy and Klumpke's palsy can be put together. So with Herb Duchenne's, the clinical scenario they'll give you is that there was a difficult vaginal delivery, and the child's head was kind of stretched, right? So what happens? Can they see me too? Can you see me? Like actually me? No. Okay, because I was trying to okay. So like if you pull your head to the side, you can feel that stretching. So what happens in this injury, this Herb's palsy or Herb Duchenne palsy, is you're actually tearing the C5, C6 roots, right? So the child's going to present like this. This is called a waiter's tip posture. It's like if a waiter's trying to get an extra tip, he kind of puts his hand behind his back to try to get a few extra dollars. But what's important about it is that if you tear C5 and C6, this is the posture you're going to get. So opposed to remembering the nerves or the ends of the nerves and which ones are involved, you can just remember this posture, right? So the child's arm is adducted close to the chest, medially rotated, and then the hand is flexed, right? So what this tells you is that the suprascapular, the axillary, and the musculocutaneous nerves are affected. Lindsey, I was told that this was not in their slides, which I don't know how you could learn this without this.
I thought this was their slides.
Was it? Okay.
Did I imagine that? Oh.
I don't know, but if you don't use this, I highly recommend it. It helps me out a lot. So like if you're talking about Herb Duchenne's palsy, you're saying, okay, C5, C6, which ones are affected? This is how I do it. So the musculocutaneous, if you label your thumb through your pinky, the musculocutaneous refers to musketeers. So C5, C6, C7. So in Herb's palsy, you're going to affect the musculocutaneous. The axillary nerve, C5, C6, it's going to be affected. Technically, if you do the 5 rats and 5 mice, that's your radial artery, your radial nerve and your median nerve. And then C8 and T1 is going to be your ulnar nerve. So it's super important that you can lay these out, because when you talk about the injuries, if you injure the root, you want to know what's affected. Now, with this injury, you also affect the suprascapular. That's because it comes off the C5, C6 branch, or the point up there. I think I have a picture of it coming up. But this is super important. But the point is, with the C5, C6 injury and the positioning of the child, you can see what sensory abnormalities are there. Okay, now if we look at the opposite situation. So for Klumpke's palsy, what they're going to tell you is somebody was in a tree, and then they fell out the tree and they try to reach for the tree and they kind of stretch their arm out. So opposed to tearing C5, C6, they tear C8 and T1. So the lower aspect of it. So if we go back to this, we're saying, okay, C8 and T1, which ones are affected? So we're basically affecting the radial nerve, the median nerve and the ulnar nerve. So that's why you're going to get Klumpke's claw, which is like a claw formation. So even though you're affecting these roots up here, they're going to affect your hand. So the more you can understand like this stuff, the less you have to memorize. You don't want to have to say Klumpke's palsy and just, you know, regurgitate a bunch of symptoms. You want to say, what's going on? Okay, we're affecting C8 and T1. What is that? Okay, ulnar nerve's affected. What's that going to give me? Well, the ulnar claw. Okay, so then a little bit more on the brachial plexus. Again, these nerves that are exits are super important because it'll tell you what muscles they innervate, right? Long thoracic, super important. They could tell you person comes in with wing scapula. Where did the, you know, what nerves affected or what muscles affected, right? So knowing a few of these, this one's not super important, but supraspinatus and infraspinatus can come into effect. And then again, for these like thoracodorsal, latissimus dorsi, those are important. So knowing these are the main points. Being able to draw this, you know, not terribly important. So by far the most important aspect are these branches. So the mnemonic is MARMU. You musculocutaneous, axillary, radial, median, and ulnar, okay? From lateral to medial. And by knowing these, you can differentiate. Knowing these and knowing the hand positionings, you can differentiate, work backwards to see what roots they came from. Okay, now, super high yield and a lot of buzzwords. What are we affecting when we have these sorts of traumas? So if we start from the more superior aspect of the humerus, if you have a fracture here, you're going to be affecting the axillary nerve. If they talk about a dislocation, the only way the humerus can dislocate is anteriorly. So what happens is this circumflex humeral artery, it actually wraps around this portion, this head of the femur, the head of the humerus. So when you have an anterior dislocation, it actually tears the posterior circumflex humeral artery. So if they ask you about that, and you could say, well, why not the anterior? Well, it's just the way it's positioning, because if you have the anterior displacement, it's going to tear the posterior side of it. So that's what you want to know. If they talk about a mid-shaft fracture, the radial nerve literally runs right along the shaft here. And the deep brachial artery is the artery that goes along with it. So anything that's mid-shaft refers to that. All right, take a look at this question real quick.
And a lot of people were asking about bone morphology. This is what we're talking about, is knowing the relationships of the bone morphology with certain structures. And so they're not necessarily going to ask you an outright question on bone morphology, but if you have a lesion, if you have a fracture, it can damage anything that's near it. So that is super important. That's the clinically relevant and the high yield information. But also when he was talking about the circumflex artery is involved in that axillary anastomosis. So they could say, okay, you're damaging the circumflex artery. What is another vessel that is now going to supply blood to the rest of the arm? So knowing those clinical correlates is really going to help you.
Yeah, all right. So for this one, it's going to be mid-humerus. Now, this was the trick that that got me. So look, when you read it, you say, let's see, where is it? What's intact? I thought it said something about. Okay, sorry, it's right here. Although he can extend the elbow, and that's what tripped me up. It's like, hold on, wait. If you're going to affect the radial nerve, which does extension of the whole arm, right, basically, how can he extend at the elbow? And it's a super important point because you can have a radial nerve injury at the mid-humerus because the branch to the triceps actually exits up before the mid-shaft, okay? So the point is that even if you fracture here, the triceps is still innervated by that branch of the radial nerve, so you still can extend the upper arm. So with a fracture to the mid-shaft here, you're not going to get effects till after the elbow joint, okay? The median nerve, if they talk about a supracondylar fracture, they're referring to a median nerve injury. And if they're talking about a medial epicondyle fracture, they're referring to the ulnar nerve. So you can see that right here. So they can just give you, they can tell you it's a medial epicondyle fracture, and they could give you symptoms of an ulnar nerve injury. And then you'll need to know that it's the ulnar nerve.
Or they'll say, where was this fracture located?
Yeah, exactly.
Presentation.
And you'll see a lot of that in the Grace questions. Okay, so this is really important as well. You can see where the skin innervation is from the branches of the brachial plexus, right? So when it comes down to it, you can see where the musculocutaneous is, and then some of the smaller branches come up. But more importantly, you can see where the ulnar nerve innervates. Again, like I said, if you next time you hit your funny bone, feel the one side and then the other side of your ring finger, and you could actually notice that the shocking, the shock from hitting your ulnar nerve actually only you can only feel it on the medial side of your hand.
So something that is super important, Brady, if you go back to that, this is really easy to pass over, but with the upper extremity, it can get hard. Lateral and medial are defined by the body in the anatomical position. And anatomical position are the arms outstretched, palms facing forward. So the thumb is going to be lateral and the pinky is going to be medial. That doesn't change. So when you're talking about the lateral sensation versus the medial sensation, what nerves are involved in that, you need to make sure that you understand the upper extremity lateral versus medial, because it can trip you up. It's a very simple concept that's easy to get really quickly, but if you don't understand that really well, you can mix up medial and lateral and you can miss a couple points.
Yeah, and just quick reference, like Lindsey said, the thumb is always lateral, and the radius always attaches to the thumb side. So regardless of how you had in your position, the radius is always on the thumb side. All right, I'd imagine you'd have a question like this on your exam as well. So try this one.
Oh, that's a buzz. Buzz.
Yeah, it is.
Statement. Holding the elbow extended and the forearm pronated. That is very characteristic.
And if they give you a clinical scenario, this is usually the situation they'll give. It's a young child and the parents are kind of swinging him while he walks. So the problem here is the annular ligament. In a child, this ligament is lax. So what happens is the the radius can actually pop out of place. It's super painful for the child, but as soon as you pop it back in place, the pain subsides. So you want to make sure you know this. And that, again, that'll be the clinical scenario. See, if you see here, this ligament is lax, so the radius can kind of just pop out of place. And typically when it happens, the arm is pronated, so to pop it back in place, you supinate the arm, and you can get it back. Another bit of memorization: make sure you understand that the ulna attaches to the capitulum, and the radius attaches to the capitulum, and the ulna attaches to the trochlea. So also, when you're looking at x-rays, note that, see, it almost tripped me up just now, but note that the ulna at the elbow is larger and gets smaller. The radius at the elbow is small and gets large, okay? And we'll look at x-rays of the wrist, and I'm gonna orient you with when we talk about Smith and Colley structures, so that you know how to identify those. This is the stuff I don't like, but some stuff you just need to memorize. Okay, so the median nerve, I don't even know if this was pointed out in lecture, but this was so, it's important.
I don't think it's very obvious in lecture.
Yeah, the median nerve gives rise to the anterior interosseous nerve. Makes sense because the median is on the anterior side. It does flexion. The radial nerve is going to give rise to the posterior interosseous nerve. Radial nerve's on the posterior side, and it handles extension of the arm. It's a little tricky because the ulnar artery will branch, and it will give branches to, and it'll branch to the anterior interosseous artery and posterior interosseous artery. So they give you any sort of injury here and they want you to work backwards. Just want to make sure you don't get these confused. All right, this is another tricky one. The flexor digitorum profundus is a tricky muscle because it's actually innervated by two separate nerves. It has two heads to it. So the medial one half, remember if you hold your hand out and your thumb's on the lateral side, the ulnar nerve is going to control the medial side. So the medial one half of the flexor digitorum profundus is innervated by the ulnar nerve, whereas the lateral one half, the thumb side, digits 2 and 3. Digit 1 is the thumb, if y'all didn't know, but digits 2 and 3 is the lateral side, and it's going to be innervated by the median nerve, more specifically the anterior interosseous branch. So you want to make sure you have this straight. Okay, so now we're going to look at the flexor digitorum profundus versus the superficialis. Now, the profundus is going to attach to the distal phalanx, okay? So like we said earlier, the median nerve is going to be the lateral side, or digits 2 and 3, and the ulnar nerve is going to attach to the distal phalanx of 4 and 5. Okay, so this is, you need to compare this to the flexor digitorum superficialis. It's going to attach to the proximal phalanx, but all of its innervation is by the median nerve. So you have to work out in your head. Let's go back to the profundus. If you have a median nerve injury versus an ulnar nerve injury, what's it going to look like? Okay. And you have to use to try to decide. So an ulnar nerve injury, you can get, so we're going to get into it in a little bit, sort of like a clawing of the hand, right? Versus a median nerve injury will be more severe because look at the joints it innervates. Okay. Let's look at this real quick. This is an x-ray I pulled. I think this would be very high yield for you to know. They can ask you these.
Yeah, it's a couple easy points, 1 or 2 questions, just straight identification. With the lunate and the scaphoid, those are associated with dislocations and fracture, but do spend a little bit of time knowing this because they could put this on here, point to one of these bones and say, which one is it?
Yeah, I have a couple of questions on it just to hammer it home. So, okay, so like we said earlier, the radius gets larger as it gets to the wrist, whereas the ulna gets smaller. And just to note, the ulna doesn't even attach to the wrist. The ulna attaches to the radius, and the radius is actually what attached to the wrist bones. Okay, so let's orient ourselves if we didn't have the words here. Find the thumb. That's always the first thing I try to do. If it's not so obvious, find the radius, right? That's the larger bone here. And then we're going to work proximally, so the radial side, and we're gonna go from thumb to the pinky, right? Or to the 5th digit. So scaphoid, lunate, triquarium, pisiform. Then you go back to the more distal side, trapezium, trapezoid, capitate, hamate. It's hard to remember. This is a great mnemonic. It's funny. I like funny. I remember funny. So there it is. Yeah, so again, we do the same way. We start proximally on the thumb side, go across, start back distally, and then go back towards the pinky. All right, so yeah, this is, I'm pretty sure you'll have a question like this on the test. So try this one. So make sure you look at what we're talking about here.
Fractured versus dislocation. Each of those has their own bone. Yeah, we're getting exactly.
So this is what they're going to say. The patient falls on their outstretched hand. So that's going to be a scaphoid fracture. I put this on here. You can see here, it's hard to orient yourself, but look, again, you can say this is the larger bone, so this is the radius, so this is thumb side, right? So the problem here is if you don't get this fixed or this, go to the doctor and get it checked out, the radial radial artery runs right around here. So if during this fracture you had an injury to the radial artery, you can actually get avascular necrosis, and it can end up causing like atrophy to the thenar muscles and stuff. So that's why that's super important. Now, conversely, check this question out.
What are you doing?
Right, yeah. Exactly. So we're talking about a dislocation. So the area of least resistance for this dislocation is posteriorly. So it's going to pop out posteriorly. So if we're talking about a fracture, scaphoid dislocation, we're worried about the lunate. All right, let's look at these. So these are very similar. It's a fracture at the distal end of the radius, and one's going to focus on anterior dislocation, and one's going to focus on posterior. The point I want to make is that what you're worried about is the disc fragment. So if we say this is a posterior fracture, the radius is here, the hand is the distal fragment. The hand goes posteriorly, okay? So this posterior fracture is a Colles fracture. So this is a good example of an x-ray they can give you on the test. So let's take a look at it. Find a thumb, okay, so palm down. So if you could see my image, the hand's kind of like this, right? So if we orient ourselves, did you have a question? Oh, maybe that was an accident. Okay, so if we orient ourselves and the palm's down, that's the anterior side, right? So this wrist, this distal fragment is pushed posteriorly, right? Because the palm's down, that's the anterior side. So this means we're looking at a Colles fracture. Now, conversely, if we look at an anterior fracture, that distal fragment fractures anteriorly, palm side, then we're talking about Smith's fracture. So look here. So if we orient ourselves, find the thumb, right? So the hand's kind of like this. So the palm's facing to the right. So you see this fracture goes anteriorly or towards the palm. Just remember, it's the distal fragment you're worried about. All right, try this one. This one's tricky, so. So you look at where the hand moves. You just want to, exactly, right? So the distal fragment is the hand. So if the hand is pushed posteriorly versus the hand is pushed anteriorly, in relation to the radius. Okay, so the key point here is the cut is down the fracture of the flexor retinaculum, but not into it. So if you didn't cut into the flexor retinaculum, you can't affect the median nerve. Remember, the median nerve, when you talk about carpal tunnel syndrome, the median nerve is what gets compressed. With overuse, the tendons in the flexor retinaculum actually compress the median nerve, and that's how you get these symptoms. So if we're talking about the anterior surface of the wrist and we didn't affect the median nerve, that means it's got to be the ulnar nerve, right? So it's also a tricky question because the ulnar nerve innervates the adductor pollicis muscle. And that's tricky because when you think of the adductor pollicis, it's on the lateral side, right? It's on the thumb side. But what happens is the ulnar nerve actually gives a branch that innervates it. So the ulnar nerve can affect the adduction of the thumb. So a couple of good points here is that the ulnar nerve does not run in the flexor retinaculum. It runs anterior to it. And it also innervates the adductor pollicis. This is a great example of a question they'd like to give you because you're thinking, well, this is on the median side, so it can't do that, the ulnar nerve, but actually it does give a branch. And they can use this for symptoms. They could say, the patient wasn't able to adduct the thumb. What nerves affected? And you're thinking about the thumb, and the thumb's on the median side, right? But it's actually the ulnar nerve. So this is from first aid. We're going to dive into it a little bit. Let's talk about the median nerve. I know the hand gets so tricky. So the median nerve is going to give rise to the thenar muscles. That's the muscles underneath if you see on the previous picture, this thenar eminence, these muscles, right? So not only that, but it's also going to give it's also going to give rise to innervation to the lateral two lumbricals, so the thumb side of the lumbricals. Okay. Now the mnemonic I like to use is loaf because two lumbricals, and then the pollicis muscles, right? So that's for the median nerve. Let's switch over to the ulnar nerve. Now we're going to look at the hypothenar muscles. Again, it's OAF, which is kind of disappointing because you liked your other mnemonic. But all these have digiti minimi in them. So we know they're on the ulnar side. Now, besides that, the ulnar nerve is also going to give rise to the medial two lumbricals, okay? So the medial side, or the ring and pinky finger. Now, the lumbricals are, before we do that, it also gives rise, the ulnar nerve, to the interossei muscles. And those are the ones that are in between. So it still gets confusing, but once you lock this down, we can talk about what these muscles actually do. So when you think of the lumbricals, and you're like, this is the tough thing about medicine, is that, you think everything goes one way and then there's an exception to the rule. So the median and ulnar nerve, they do flexors all the way down, right? All the way up to, for the hand, except for these joints for the lumbricals, okay? So like we said, the median nerve is going to give innervation to the lateral two lumbricals, and the ulnar nerve is going to give innervation to the medial two, right? So if you look at this depiction, the lumbricals are going to flex at the MC joint, like holding a P. So they're going to flex at the MCP joint, but they're actually going to extend at the PIP and DIP joints, right? So they're typically flexors, but in this exception, because of the way this is oriented, the lumbricals will help to extend at the DIP and PIP joint. Now, this comes into importance when we talk about some of the injuries, but let's look at the interossei muscles real quick. So this is the mnemonic you're going to want to use, DAB pad. So for the dorsal interossei, DAB refers to the dorsal interossei abduct. So the interossei, all of them are innervated by the ulnar nerve. The dorsal ones will abduct. So they're going to take your hand and they're going to spread them apart, right? Abduction. Whereas the palmar interossei are going to adduct, right? So it'll take your hand and put them together. So if you remember this, you can keep these straight. And again, the ulnar nerve helps to innervate it. So when you talk about adduction and abduction, you need to have a center point of center axis. And so you use the middle finger, right? So abduction and adduction, right? Okay, try this one. Yeah, very good, right? So we're talking about the benediction hand, or the Pope's blessing, right? If you can see my image right now. So yeah, we're talking about a median nerve injury. Now, it gets a little tricky, and this is from first aid, and you kind of need to wrap your head around this. So this ulnar claw configuration, this is when you're trying to extend the fingers, right? And this is why the lumbricals come to importance, because you're saying, why are we talking about the ulnar nerve when we're talking about extension? That's because the lumbricals are affected. So you can take this one and say, this is an ulnar claw when you're trying to extend, but let's jump over to the one all the way on the right. If you were trying to make a fist, okay, then you're talking about these ulnar flexors here. That won't work. Conversely, if you look at the median nerve, you can see the Pope's blessing. And again, this is making a fist. You can't. These ulnar nerves, these muscles that are innervated by the ulnar nerve can contract, but the median nerve cannot. Then when you talk about extension, the lumbricals of the ulnar nerve that are innervated by the ulnar nerve work, but they don't for the median nerve. So again, you want to try to do it both ways, right? Is the patient presenting with this? Are they trying to make a fist or open their hand? Are they at rest? So you want to just do it. And then as long as you know where and how the muscles are supposed to work, then you can figure out where the deficiency is. And that's all I have for upper limb. If y'all have any questions, Lindsey was kind of answering them. Again, this will be posted on Scrubs DES, and we're going to try to post the recording too. If y'all don't have access to the Google Drive, y'all can snap a picture real quick, and you can get on the Google Drive. I'll put the link too in the thing so we can move on.
Yeah, so make sure that you have a understanding of the upper limb before you go, because the upper limb is very high yield. The hand is very confusing because there's so much that can go on in the different presentations, like Benedict's hand, claw hand. Know all of those buzzwords because it can get really confusing. And then when you move on to abdomen, pelvis, you have a working understanding of upper extremity already.
And for sure, go ahead.
So for the hand, do they just mainly stick to the clinical correlations they told us?
Yeah, for sure. They're going to give you a situation where a patient comes in and they're going to have deficiencies, and you're going to want to wrap your head around it. But like I pointed out here, yeah, I can go over it again. So, but what you're going to want to know is how these deficiencies are going to show up clinically, right? Let's see, let's try that again. Okay, so typically when we think about it, the ulna and median nerve, we're thinking about flexion, right? But you have to remember that the lumbricals will help to extend these joints, right? They will extend the PIP and DIP. So the first picture and the last picture correlate to the ulnar nerve. So if you see under context, you see when the patient tries to extend the fingers or if they're at rest. So this patient's able to extend the second and third digit, but they're not able to extend the fourth and fifth. That's because since the ulnar nerve is affected, the lumbricals that innervate this fourth and fifth digit won't let the PIP and DIP extend. Okay. Now, conversely, if you look at this side, if you're trying to make a fist, that's our typical understanding of the ulnar nerve. It's supposed to flex the pinky and the fourth digit of the ring finger. So the median nerve is going to not be affected. So you're able to make a fist. But these medial two or fourth and fifth digits are the ones that are affected. Now, if you look at the median nerve, when you're trying to make a fist, so the fourth and fifth digits are able to close, but you won't be able to flex the second and third digit. And then extending, that's when we talk about the lumbricals. Since the lumbricals to the second and third digit are affected, you're not able to extend the second and third digit. Okay, so keep these in mind. Typically, you're going to you're going to think about the flexion aspect of it or making a fist and stuff, but I don't want them to trip you up because the lumbricals do come into effect when you think about these. It's a good exception to know.
Okay, I want to quickly go over the thorax with you because we haven't really talked about that yet. So I'm going to share my OneNote screen if you guys want to click on my picture, because there's a lot of high yield stuff in this DLA that I want you guys to understand. So this is the DLA on the thorax. This is that bone morphology talking about this. But if you go down, you need to understand, so this is something we talked about in my PLGs. If you notice, the main neurovascular bundle for the ribs is located in this little notch on the inferior aspect of the rib. So if you're inserting a chest tube, you don't want to hit this. So you're actually going to orient the chest tube on the superior aspect of the rib. They ask, I think, 3 questions in your Gray's book about this. It's a really simple concept that you just need to know a couple easy points if you understand this, but make sure that you understand you need to go to the superior aspect so you're not damaging.
Real quick, listen to the terminology here. You're going to the superior aspect of the inferior rib.
Yeah.
Okay? That's the point you want to insert the needle at, the superior aspect of the inferior rib. So don't get confused because they could put A, B, C, and D and flip those around. But the point that Lindsey's cursor's at, that is the superior aspect of the inferior rib.
Yeah.
That's where you want to go.
So let's say this is 4 and 5. If you want to go between intercostal space of between 4 and 5, you want to go to the superior rib of the inferior, which is going to be 5. So that's the space you want. Does that make sense? That terminology was probably, we went fast. You need to know that concept. Okay, cool. So
repeat it again one more time.
Okay. So say we want to insert a chest tube and we want to insert it between the ribs to 4 and 5. So the intercostal space of ribs 4 and 5. So if you want to go in that space, you're going to find the inferior rib, which is rib 5, but the superior border of that. So this is going to be the inferior rib of this little relationship, but you're going to go to the superior border of that rib to avoid the major neurovascular bundle that's hanging out below this rib right here. So this little groove right here, this is where all the good stuff is. You don't want to hit that. So go to that inferior rib of the intercostal space and then to the superior aspect of that. Cool. I don't think they went too big into like the deep muscles of that, but rib movement, you do need to know the difference between these rib movements and describe it. So the cutesy.
Can you, Lindsey, can you make those slides a little bit bigger on your screen?
I have to change it's following me. On Zoom, it doesn't follow me.
Oh, there we go. Yeah, that's better. Yeah, these movements are super important. So you could see this pump. Well, the pump handle movement, if you look at the illustration is really good, actually. If you look at the pump handle, you're increasing your thoracic cavity by going anterior posterior, okay?
Yeah.
Whereas the bucket handle, you're going side to side. So you're increasing the diameter from the lateral diameter. I do remember a question like this.
Yeah.
And the whole point of doing this is you're increasing well, you'll get into it in pulmonary, but you're allowing the air to go in, right? You're making a negative pressure vacuum by doing like that, so the air rushes in. But yeah, know the idea of the pump handle versus the bucket handle movement.
Yeah.
And also, by far, the most important is the third, which is the diaphragm. You have this anterior posterior movement. You have the lateral movement, but the diaphragm relaxing and contracting is the most important movement for air inspiration.
Yes. Yeah.
So there's three.
Be big in CPR too.
Yeah.
Okay, now when we're getting into the pleura, think about pleuritis, the phrenic nerve. If you take a really big deep breath in and you get pain from that, that's called pleurisy because you have inflammation of the pleura and it's rubbing together and you get that pain. That's the phrenic nerve. So know the new nerve roots for that. But the big thing here is this. Because when you're placing a chest tube, you want to make sure that you're putting it in the place that you're going to get the best result. So mid-axillary, mid-clavicular, paravertebral, know what they correlate with. So mid-clavicular, you would put it between ribs 6 and ribs 8. So yeah, so the inferior border of the lung, this is going to be 6, inferior of the parietal, rib 8. So just know these boundaries.
And think about it like this, right? So if you had pleuritis and you had fluid buildup, the fluid's going to build up in those little blue areas, right? So typically,
diaphragmatic recess.
Exactly. So what they do clinically is they go in mid-axillary, right? So from the side. And from that's typically where you're going to go. So you want to go around rib 9. And by doing that, you're going to miss the lung, but you're going to still be in the pleural cavity. So you can pull that fluid out at the bottom.
Yeah. So this is very testable information. So make sure that you understand this concept because it's directly applicable in clinic. So make sure you understand that. Of course, okay, so this is the thing that we went over. If you do a pleural tap thoracentesis where you want to orient your needle or tube with respect to the neurovascular bundle. Dermatomes, you need to know these high-yield dermatomes. They can test these dermatomes, or I remember they tested a dermatome that was adjacent to one of these dermatomes, and the only reason I got it right was because I knew what the high-yield dermatomes were. So make sure that you can do this. They love the herpes zoster one, the dorsal root ganglia. because the herpes zoster lives in a dorsal root ganglion. So if that cluster of viral particles is activated, it's going to affect that dermatome in which that DRG is living. And so, I mean, they could ask you the dermatome, they'll ask you, the dorsal root ganglia.
They could even give you an image, and you can see that the rash goes in a strip pattern across the back, and then they could ask you what is it, and that's because it's in a dermatomal pattern.
Yeah.
So most importantly, the T4 is the nipple line, and T10 is the umbilicus. So you can work the rest out, right? If you know T4 and T10, you could kind of figure the rest out. But yeah, definitely know that the herpes zoster, which is shingles, by the way.
Anytime they say anastomosis, you need to know that thoracics. Did they the presentation of breast cancer? Did y'all go through that yet?
Yes, we did.
Okay.
Okay.
That is super high yield. You need to know the difference between the orange effect and then like the suspensory ligaments, because it's two different signs and it's different, and it goes through a bunch of them in grays. And so make sure you map that out, because those are very high yield, but they're very easy to get confused, and there isn't a lot of information in your lecture slides about it. So make sure the POTA orange, I think that's what it's called, and then you have the dimpling, the rippling of the areola, which is due to the suspensory ligaments, and so
they get contracted.
Yeah, so make sure you know that. And then the lymph nodes, when they talk about lymph nodes, they're talking about the very first lymph node that's going to receive lymph from the affected organ. In MSK, I remember there are a couple ones that they give you this really long pathway, and it intimidated me initially. But they're going to ask for the first one because it's very applicable clinically, because if you have a metastases from an area, it's going to go to that first lymph node first.
The way I remember it is, so they could ask you about metastatic breast cancer. So the first node is going to be typically the axillary node, excuse me. So it either goes to the peristernal or the axillary. But another question they ask is, a guy got stabbed in the back. Yes. Around the scapula, and they could ask you about the posterior node. But the idea is that these nodes, they're kind of like highways that go to the interstate, and the interstate is the central node. So everybody's trying to get there. The lateral nodes are coming from the arm. So you can think they all kind of converge into the central node, and then they go up to the apical node. So just know, like Lindsey said, the first node to receive whatever the problem is. There's a good example of herpes zoster.
Yeah. Oh yeah, it's in this lecture. So you do need to know these terms: polymastia, polythelia, gynecomastia. That's fair game on it. They break this into different quadrants because I believe one quadrant is going to go to a different lymph node than the others. But this is what it is: the Sunkist orange effect, the POTA orange versus, and there's another one that is kind of a rippling effect. But the suspensory ligaments, that's what's doing this. These are, there's another sign that's completely different from this, so make sure that you know. And then there's a lot in here that is applicable that it can test you on. So if you have a radical mastectomy, you can have residual signs from that, like lymphedema. You can, because there's like a little tail right here, and you can often damage it's right here. You can often damage nerves right here, because you see this overlies the brachial plexus. And so this is a really big thing that they can test you on, is you get a radical mastectomy, couple months or couple weeks later, the sentinel node is the definition of, okay, thanks, Brady.
Yeah.
So a couple months or couple weeks later, a woman comes back with papilledema, or lymphedema. So the arm is really enlarged because the lymph structures are ligated, and so you're not getting lymph drainage from that extremity, and so it's going to build up in that extremity, and that's the lymphedema. So that's a common, or not common, but it's a very testable presentation status post-radical mastectomy. It's a if you damage these structures. So make sure that you do understand that concept. This is the lymphedema.
Yeah,
Lymph gets backed up here because it can't get out of that extremity. I've seen it in clinic. It's not pleasant. So this is just telling you landmarks and AP. Do you remember a lot about rib fractures on there?
No, not until not until we got to pulmonary.
Yeah, you can get a
Then maybe
flail
that.
chest.
Yeah, the whole point of a flail chest is if you have a fracture, when you take a deep breath in, the flail chest will go opposite.
Mm-hmm.
Okay, so if you take a deep breath in, the portion that's broken will kind of sink in. When you expire, the portion will jut out. So it has an opposite effect to it.
Yeah. So pleurisy, know the nerve. It's the phrenic nerve. It can radiate into the. Can get shoulder pain as well. Neurovascular bundle, thoracentesis, we went over that. So the landmarks, again, hitting this hard. In DL8 had this exact same chart. This is very high yield, and it's very clinically relevant. Okay, whenever they distinguish somatic versus visceral, this is extremely, extremely important because it's different nerve pathways. So somatics, to the thoracic wall versus visceral to a body organ. So make sure if they are distinguishing the type of innervation and what kind of nerve it is, that you make note of that. So this is talking about the phrenic nerve. So phrenic nerves is going to be somatic sensory nerve, and C3, 4, 5 keeps the diaphragm alive. But that's the thorax, and I wanted to go over that anastomosis real quick because it is super high yield. So let me see if I can find that.
I had a quick question. So with the somatic versus visceral, are we also really having to know the voluntary control of the skeletal muscle in the body walls because of somatic efferent, and then the visceral is involuntary control, like autonomic, in relation to what you were saying?
Yeah, so they could ask that. I think more importantly is to know that the parietal peritoneum, you're talking, or the parietal pleura, same principle, is somatically innervated. So you're going to get somatic pain referred to it. So you can keep that on the somatic end of it. So it's more of like a pinpoint pain, whereas the visceral pleura or peritoneum, you're talking about more of a dull, achy pain, and that's related to the visceral afferents.
Yeah, like can you take your finger and point to it?
Yeah, that's typically somatic pain versus visceral pain. If they ask you a question, it'll be related to pain. But again, that's more of a pulmonary type issue. Okay,
so the question everybody keeps asking is, what about the arteries? What do we need to know? So anastomosis, because if you ligate an artery, distal to that ligation, you can get ischemia and then necrosis. And so collateral blood supply is going to save that distal area from that effect. So this maps this out. So you can go and you can draw this out, you can map this out, but the big thing is the scapular anastomosis. You need to know this anastomosis. So you have the dorsal.
Yeah. So sorry, the way I remembered this, they all have the word scapular in it. I think that was like a trick that was in Gray's, I think. Yeah, so the anastomosis here, when you're looking for it, they all have the word scapular in it.
Yeah, but you also need to know that like suprascapular is coming from the subclavian, circumflex is from the third part of the axillary, dorsal scapular is coming from the subclavian, because these branches are going to create this collateral blood flow, and if one of them gets ligated, so they could say the third part of the axillary nerve is compressed or ligated, transected, whatever, like what is going to supply collateral. Supply the collateral blood supply to the rest of the limb. So that's really how they're gonna do it. So this goes into the spaces. Okay, we've done all that, but I wanted to hit that artery, that anastomosis right there. But I think we've gone through all of the week 8 stuff. Yes, is there anything else that you guys can think of that you want to run through? Any questions that you have, something that is really not sticking with you?
The hand's the worst.
Yeah, the hand is very confusing because there are a lot of little muscles that like the innervation and all of that. The grades questions, honestly, doing those and then reading the explanations to those is how I learned it really well, and it stuck with me. Brady and I both said before that looking at the lectures doesn't really give you the sense of what you need to know. It's very one-dimensional. It's a bunch of charts, it's a bunch of graphs, it's a bunch of pictures with labels that's not really grouped together in a very cohesive way, and it gets really confusing. And so do those grades questions, even if you feel like it's too early. It's not too early to start doing those questions. Like, it's going to help you learn the material. Don't just do questions to test yourself. Do questions to learn, because you're finding your deficits. You're finding where you need to spend extra time, but you're also orienting to yourself to, how is this going to be asked of me? Okay, so I know this grouping of muscles, I know their innervation, but what does that even mean? How are they going to test this? What does it look like in a patient when this is when there's something wrong? And so make sure that you are going through that. It is definitely not too early to go through all of those Graves questions, especially since you're going to start abdomen and pelvis. And I personally thought the pelvis was a little tricky as well. So make sure you get the upper extremity, get a decent working knowledge before you move on to the next stuff.
And I think especially for the hand, like I tried to do in the PowerPoint, like try to group things together, like the hypothenar versus the thenar muscles. Is the foot as bad as the hand? Yeah,
No.
It is.
Oh,
She's
I
positive.
didn't think it was as high.
No,
because all of the lumbricals and everything, I feel
Yeah.
like they test more the little muscles in the hand. I felt like it was more broad in the foot.
Right. Yeah. Yeah. Well, you have a background, so.
Yeah, I was in podiatry school for 2 years, so
that might help. But anyway, yeah. So, like I said, for the hand, try to group things together. Like first find the nerve. Where's the nerve going? Then group the muscles together for that nerve, and then you can find a deficiency. But like Lindsey said, you can only look at slides or PowerPoint so long. You really need to do the active learning and go through the questions. So just learn from that.
And draw on yourselves. Act these motions out. MSK is very unique in that you can test the motions of yourself and you can feel what muscles are being activated by different motions. When we got to the lower extremity, I would like stand on one leg and I would say, okay, what's activated on the right and what's activated on the left to keep you from falling over, that kind of thing. So okay, any more questions? I think this was a really fruitful session. We are thinking about trying to do this every weekend. This is actually a really good review for us too, because we are tested on term 1 and term 2 at the end of term 2. So this helps us a lot. Like, you guys think it's just helping you, it's helping us as well.
Yeah, for sure.
We're getting good benefit from this.
Actually, Brady and Lindsey, you've been very helpful. We really appreciate it. I have a quick question because we have the MSK Lab 2 coming up on Monday, and then also small group 4 on Tuesday in different groups. So looking prospectively at the lab exam, that's going to be at the end of the term, along with the online clinical evaluation exercises, OSEX. Are we going to be able to have more more of a clear path for those when we get closer to it? Like, should we focus on MSK right now? Will this MSK material be heavily tested at the end of the semester before the 5th exam?
So, okay, disclaimer, we didn't have to do the OSEX or we didn't have to do the lab exam. So I can't really speak on the OSEX. I don't know how they're going to set that up for y'all, but I can say for the lab exam, I would try to look at cadaver images now. Like, you should be looking at upper limb images now because it is a different beast when it's not color coded for you. So I would try to look at that now because you don't want to wait until a few days before the lab exam and try to learn everything in the cadaver. So I think primarily you want to pay attention in the lab sessions to see what they're pointing out and the images they're pointing out, the different, the orientation, I mean, that they want you to know. But I definitely wouldn't wait too long to look at that.
Thank you.
Yeah, this term is new for us too, because like we said, MSK was the first test we took online, and we were a week into MSK, or like 2 or 3 days into MSK, and everything was normal. Everything was absolutely normal. And then we get an email at like 7 o'clock, 7:30, basically saying, get off the island, essentially. Oh. And so like the test was pushed back. I think at the end it was like 2 weeks because they were trying to facilitate getting thousands of students off the island. And then, everybody was trying to resettle and figuring out everything. So they actually pushed the end date of the whole term back to accommodate everything. And so like the lab exam, the OSEX, all of this is new to us too. So we feel y'all.